Hello, my name is Dr Dima El-Sharkawi and I'm a haematology consultant at the Royal Marsden Private Care. I'm going to talk to you about lymphoma, which is one of the, it's several diseases actually. We've got lots of different types of lymphoma, but it's one of my interests. So I want to start by presenting a case to you, just to highlight how sometimes patients can have quite a prolonged pathway before the diagnosis is made, and it's not always clear-cut. So the case that I want to present to you is about a 22-year-old lady who had presented to her GP with some neck lumps. Now, she'd had some viral illness. It was thought it could be due to an infection, very reasonable thought. And the GP very appropriately said, let's see what happens to these neck lumps and come back to me if they don't disappear. So safety netted the patient. So the neck lumps reduced slightly in size, but then they were still persistent. So she returned back to her GP and then was referred on to the hospital for a biopsy of one of these lumps. Now, rather than have a biopsy, she had an FNA, so an aspirate, and that didn't show any malignant cells. So the liquid that was taken from the lymph node didn't show any evidence of disease, and so she was discharged back to her GP. But these lumps persisted over a year. They would come and go, they would wax and wane a bit, but they were persistent. And so the patient ended up having a biopsy, again didn't show any malignancy, and then had another 1 or 2 biopsies before a diagnosis of Hodgkin lymphoma was made. I highlight this case not to say that anyone had done anything wrong at any point of this path, but just to show that even a biopsy that doesn't show a malignancy to begin with doesn't 100% rule it out. And we know, particularly with lymphomas, which is a cancer of the immune cell, and lymphomas such as Hodgkin's disease, actually the malignant cells are very few and far between. And when you do a biopsy, it can sometimes be hard to see these malignant cells. And most of what you see in the biopsy are the other normal immune cells reacting to the malignant cell. And so it's to highlight that, particularly in patients with persistent symptoms, persistent lymphadenopathy, even if you have a biopsy that hasn't shown any evidence of malignancy, particularly if it's just an aspirate or a core biopsy, so small biopsies, that your index of suspicion still needs to be there, that this could be something significant and could be malignant, and that just the initial diagnosis was missed, so to speak, because the malignant cells are few and far between. So one of the reasons that I like lymphoma, I find it an interesting subject, is that the way that patients present can be so varied. I mean, we have many patients who just present with incidental findings of an enlarged lymph node. So either they happen to be very well and notice a lump, or they have a scan for another reason and the lump or the enlarged lymph node is identified. But in patients that are symptomatic with lymphoma, I tend to think about the symptoms in 2 separate sections. So patients can have localized symptoms from the enlarged lymph node. So they might notice the lump, as I've said. They may get pain from where the lump is. If the lump is near, or the enlarged lymph node is near nerves and pressing on the nerves, then they may get neurological symptoms related to that, for example. And then there are the generalized symptoms, and we often talk about B symptoms, which is significant weight loss, or drenching night sweats. And when we talk about drenching night sweats, the patients often end up having to change their bedclothes, change their pajamas or nighties, because the night sweats are so bad. So this isn't just that they're feeling a bit sweaty at night, this is properly soaking the bed. Patients can also get pruritus, so itching, and it can be quite significant. So again, we've had 1 or 2 patients with Hodgkin's lymphoma who've presented with intractable itching that has been diagnosed as eczema for about a year before the diagnosis of Hodgkin's lymphoma has been made. And then there can be other presenting factors as well. So some patients can have changes affecting their blood. So some patients may get, for example, a raised calcium, particularly if their bones are affected by the lymphoma. And some patients, even with lymphoma, can get a paraprotein. So you may get an increase in globulins or total protein that's picked up on blood tests. So I think the symptoms can be very, very varied, and so it's always important to think about them. And I think one important thing, though, to consider is that a lot of our patients, in fact, most of our patients with lymphoma, have normal blood tests. So whilst some patients do have abnormalities on their bloods, having a normal blood count or basic biochemistry screen is not a sensitive test for ruling out lymphoma. So I talk about lymphoma like it's one diagnosis, but it's not one diagnosis. We've got over 50 different subtypes of lymphoma, and as our knowledge about lymphomas increases, so how we categorize them is changing. Every few years there's new international consensus guidelines on how best to categorize them, which can make it confusing for hematologists, let alone non-hematologists, to understand all the complexities. But let me break it down for you into the simple and what I think you need to know. So lymphoma can affect either your B lymphocytes or your T lymphocytes. So we've got B cell lymphomas and T cell lymphomas. We've got a particular type of B cell lymphoma called Hodgkin's lymphoma. And anything that is not Hodgkin's lymphoma comes under this umbrella term of non-Hodgkin's lymphoma. So like I said, non-Hodgkin's lymphoma encompasses many different types of lymphoma, both B and T cell lymphomas. T cell lymphomas are quite rare and usually quite aggressive. From the B cell lymphoma side, so the B non-Hodgkin lymphoma, there are high-grade lymphomas and low-grade lymphomas. And this usually just reflects how quickly the cells are dividing. So the high-grade lymphomas, the cells are more rapidly dividing. The low-grade lymphomas, more slowly dividing. Of course, these are broad brushstrokes and there is crossover there. This can impact how patients present. So generally speaking, those patients with high-grade lymphomas are more symptomatic. We think the disease is likely to be a much faster growing disease. They are more likely to have the generalized symptoms, so decreased appetite, weight loss, night sweats. The lymph nodes are likely to be rapidly increasing in size and can be quite large, whereas the low-grade lymphomas, often patients are quite well and it's more of an insidious onset of disease. Patients might notice a lump but otherwise feel well. Of course, like I said, there is overlap, so we can get patients with high-grade lymphomas that are relatively asymptomatic and those with low-grade lymphomas that are quite bothered by their symptoms, but broadly speaking, that's how they present. Of course, the only way to absolutely differentiate and to diagnose the subtype of lymphoma is by biopsy. Like all cancers, biopsy is key. But if you think about lymphomas as high-grade or low-grade B non-Hodgkin's lymphoma, that also helps the way that I think about our treatments and our goals of treatment with these different subtypes of lymphoma. So most our treatment for lymphoma is chemotherapy-based, and chemotherapy is quite a blunt instrument that treats rapidly dividing cells. And so actually those patients with high-grade lymphomas, by their inherent nature of their disease being a rapidly dividing disease, their diseases are more susceptible to chemotherapy. And so when we give chemotherapy to patients with high-grade lymphomas, our aim is curative. We're hoping that the treatment will get rid of the lymphoma completely and that the lymphoma will not come back. Whereas with low-grade lymphomas, we can give those same treatments to patients with low-grade lymphomas, and we can often induce a remission. That is, that we can get rid of the disease by our powers of detection or reduce the level of disease significantly. But the treatment is not curative. It controls the disease perhaps for years, sometimes perhaps for decades, but we know at some point the disease is likely to come back again. And so for those patients patients with low-grade lymphomas or more indolent and slow-growing diseases such as CLL, because the treatment is not curative, a lot of the time, if patients are well when they're first diagnosed, we don't necessarily treat them straight away, and we might observe them for a while and only start treatment once they are symptomatic. This can be quite difficult to talk about with patients because, it goes against what everyone understands about cancers, that early diagnosis leads to earlier treatment, leads to better outcomes. But with our low-grade lymphomas, because the treatment's not curative, we know that sometimes patients can go for many, many years without needing treatment. And so why subject them to the side effects of the treatment from the beginning? I will use Waldenstrom's macroglobulinemia, which is one of our low-grade B non-Hodgkin's lymphoma, as an example of how the disease may present. So when I think of Waldenstrom's, and I might shorten it to WM, otherwise it's going to be a tongue twister for me to say several times, I think of it in 3 different sections. So I think of the impact of the lymphoma on the bone marrow. So not all lymphomas affect the bone marrow, but Waldenstrom's or WM often does. And so when you get too many of the abnormal cells, then it replaces the function and the production of the normal blood cells. So patients may present with low blood counts and the symptoms of their low blood count. So they may be anemic and become tired and develop shortness of breath on exertion. Their platelets may go low, and so they might be more prone to bleeding or bruising. And their normal white blood cells may be lowered, and so they'll be more prone to infections. So that's how it may affect the bone marrow. And WM often particularly seems to affect the hemoglobin. So patients can often be quite anemic when they have significant infiltration of their marrow. Then patients can sometimes have enlarged lymph nodes, and we've already talked about the symptoms patients may get with enlarged lymph nodes. And the third aspect of WM is the paraprotein. So this is the abnormal antibody being produced by the clonal or the malignant lymphoid cells. So this, in the normal counterpart would be the immunoglobulin that would help fight infection, whereas here these clonal cells are producing this clonal abnormal antibody that can be picked up by protein electrophoresis. Now, if this is very, very high, patients can present with symptoms of hyperviscosity, where it affects the small vessels in your body. So it can have an impact on the kidneys. Patients can have headaches, visual disturbances, or nosebleeds as well. And that's related to the level of the paraprotein. But WM also, some patients, their paraprotein can have unique properties that in itself can cause complications, such as amyloid, which can affect the kidneys. It could potentially affect the heart, or cause immune destruction and immune problems as well. So some patients can get an autoimmune hemolytic anemia, where the antibody leads to breakdown of the red blood cell. So another way that patients with WM can become anemic. So that, most patients with WM, their paraprotein won't have these different unique properties, but it does mean that patients can present with quite varied symptoms and through varied mechanisms. I want to highlight to you one of the exciting newer ways of treating lymphoma that we have been doing for a number of years for a type of high-grade B non-Hodgkin's lymphoma called diffuse large B-cell lymphoma. You may have already heard about it, but it's something called CAR-T therapy, which stands for chimeric antigen receptor T-cell therapy. So this is a completely different way of treating lymphomas. It's also used now for myeloma, for acute lymphoid leukemia, and there are lots of trials investigating it across a whole host of hematological malignancies and solid malignancies, and we're participating at the Marsden in some of those trials. So CAR-T therapy is where we use the patient's own T cells, so their normal immune cells, to help fight the cancer. These T cells can be collected from what looks like a dialysis machine, so patients are hooked up, we collect the T lymphocytes and they get sent away to a laboratory, often abroad, to be made to express a receptor that's going to target your cancer of interest. So for the routine standard treatment that we give, for example, DLBCL, so the lymphoma, it targets something called CD19 that's on the surface of all the B lymphocytes. So these cells are made to express a receptor that targets CD19, and they're expanded in the lab, so they're increased in the lab. And then that cell product is returned back to the Marsden, where we can then deliver it back to the patient. And so the patient has got their own T cells equipped and weaponized, if you like, to help try and fight the cancer. This is an effective therapy for many patients and is a very exciting, innovative way of treating lymphomas. So hopefully you found this quick summary on lymphomas interesting and helpful for your everyday practice. I think my key take-home points are that lymphomas can present in varied ways. Obviously, there's the more usual common ways that they present within large lymph nodes, in large glands, but don't be fooled by lymph nodes that wax and wane in size, because that can happen, particularly with certain lymphomas, such as low-grade lymphomas or Hodgkin's lymphomas. And also don't be fooled by a normal full blood count, which is not a good screen for screening out lymphoma. And finally, for lymphomas, FNA, so fine needle aspirates, are often not a good way of excluding a lymphoma. And so if you are suspicious of a lymphoma, ideally we need biopsies, and ideally our pathologists would say removing the whole lymph node, but failing that good core biopsies to try and increase our likelihood and sensitivity of picking up the disease. Thank you very much for watching.
We hope you found the session informative and useful. If you have any questions about it or want to know more about referring patients into private care at the Royal Marsden, do please contact me. And likewise, any information or feedback on these sessions is always gratefully received. Thank you very much and take care.